Hello from me, Norman Swan, and welcome to this ninth and final webinar in the Rural and Remote Response to COVID-19 series run by the RDAA and ACRRRM. Thank you for joining us tonight from all over Australia. It's great to have you. Our panel is a panel of presidents and chairs. ACRRRM President Dr. Fiona Wake from Emerald, rural generalist and obstetrician. The RDAA President, Ron Hall, who's Director of Medical Services at Ochre Health, and is a rural journalist and obstetrician at Cooma. RACGP President, Harry Nespolon, who's a general practitioner in Sydney. AMA President, Dr. Tony Bartone, who's GP from Melbourne. Australian Indigenous Doctors Association, AIDA President, Dr. Kristopher Rallah-Baker, who's an ophthalmologist, Sunshine Coast in Queensland, and Chair of CRANAPlus, coming to us from Darwin, Fiona Wake. Welcome to you all. And before we go any further, I'd like to throw to Kristopher Rallah-Baker to acknowledge country for us.
Thanks very much, Norman. So I'd like to acknowledge the lands of the traditional owners on which we meet tonight across our continent. I'm a Yagara Warrangal man on my mother's side and Wiradjuri man on my father's side, and I currently am on Gubbi Gubbi country on the Sunshine Coast. I'd also like to acknowledge elders past, present and emerging.
Thanks, Chris. Now, for those watching, you can ask questions. You click on the Q&A icon on the bottom of your screen, and it'll open a window allowing you to ask questions of the panelists, and then click send. Otherwise, we won't be able to see your questions, and I'll try and follow you here on the screen. And so the idea tonight is kind of, I've been taken with an ice hockey metaphor, which is that you don't play where the puck has been, you play where the puck is going to. And where is the game going to in terms of primary healthcare, rural healthcare, remote healthcare, moving forward following this very intense period, which is not over yet. I might start with you, Ewan. I mean, just capture a couple of the issues that are preying on your mind at the moment.
Thanks very much, Norman. Look, one of the major ones for me is the fact is that we're not out of this yet. That my staff, myself, we've been doing 60, 70 hours a week in the practice, keeping the doors open, running our GP-led clinic, and just trying to bring the community on the journey with us as we continue to try and make sure that we're diligent about this virus, but also the issue of ensuring that our patients are getting the care they need. I think mental health is really starting to become an issue for us. And to say the other big issue for me, therefore, is the workforce. That we don't have the workforce coming through, both specialists and generalists, that we need to address what I think is going to be a real tsunami of mental health issues and other health-related issues in rural, regional, and remote Australia over the next 12 months to 2 years.
What mental health issues are you starting to see?
Look, to be honest, psychosis.
Psychosis?
Yeah, we've had two psychotic patients this week. Look, there's probably a bad batch of ice going around at the moment, I think. But severe anxiety, depression, people just really facing financial difficulty, financial ruin, and significant uncertainty. One mine fired 160 workers yesterday because, you know, the coal's not going anywhere. It's sitting in ports. China ain't buying it. So we've got these major economic issues happening for people. We've got people stuck at home. We've got access to drugs and alcohol. It's really quite a volatile mix at the moment.
I'll come back to the workforce and implications of that. John Hall?
Yeah, look, for us, workforce has always been one of our key issues. We're really concerned about the disruption to the training pipelines from medical students not going into community practice and rural hospitals, but also registrars and also specialty trainees, with some colleges suspending training for up to a year. So we're working from a base where we don't have enough workforce now to think that there'll be disruptions to that pipeline. It's just going to double down on what's already a crisis. But I'll leave the training issues to the colleges tonight. For us at the Rural Doctors Association, we're hoping to use this crisis as a real impetus.
Hold on a second, but just hold on 1 second, John. I mean, Clemenceau said that war was too important to leave to the generals. Are you going to leave training to? Are you honestly going to leave training to the colleges?
Well, I was more talking about tonight, letting them discuss it at length, because I've got some other, I think, primary care and rural health reform things that I wanted to get to. But look, we'll certainly hold them both to account, not both, all of the specialty colleges to account. When it comes to getting doctors into rural and regional Australia, we're just as concerned about getting our specialty trainees. And when the College of Ophthalmology says it's going to suspend training for 6 months, that concerns us about access to ophthalmologists in our regional towns, which our rural patients and communities and doctors rely on. So we're very concerned about training. We're concerned about delays in the rollout of the National Rural Generalist Pathway. We're concerned about the department stalling on things like the single employer pilot models that go into the rural generalist pathway, and also the lack of trainees wanting to do general practice and rural practice at the moment. So we're certainly very concerned about those issues, and we will hold colleges to account if we feel that they're not doing enough to make sure that they're playing their part, and certainly hold the department to account if it's not assisting the colleges in their work as well.
I mean, one of the things I'll be exploring tonight is whether there's an opportunity for a unified response on some of these issues, because I suspect the panel is in agreement with a lot of this. Kristopher Rallah-Baker, there was a lot of concern about Aboriginal communities at the beginning of COVID-19, particularly remote Aboriginal communities. There was a whole problem in South Australia with elders not being able to get into Adelaide to, in a sense, provide an island of safety in Adelaide for Central Australian elders who were at risk. What are you hearing from communities, and in a sense, what are you hearing from the community-controlled sector as well that we can learn moving forward?
So I think, as a lot of people are aware, we've been very lucky as a country, and as a population that was at high risk, we've been extremely lucky that to date there have been no cases reported in rural remote. There was a period there where we were very concerned when cases were being isolated, particularly across the Kimberleys. The probably single most effective step for Indigenous communities was the early closure of those communities. And in fact, well before the federal government was releasing policy at a national level and really guiding through the issue as quickly as they did, there were responses from late last year amongst community-controlled organisations talking about exactly these issues, preparing to close communities, preparing people who were in communities where there were homelands and outstations to go back to those outstations. So in many respects, we, as a subgroup of the population, were ahead of the curve and were able to implement those changes very early. There's been some quite interesting data coming out that there's a possibility the BCG may be protective, and there's perhaps some evidence that that's to do with, I think it was receptors or something, that there may be some genetic influence there as well that may have contributed to the success. We've had 56 cases in, it was outer metro areas and Western New South Wales, but they seem to have been got on top of and no deaths. So I think the Indigenous response was certainly impressive in terms of the collaborative effort and the early formation of a task force that involved AIDA, NACCHO and other peak bodies, including allied health, nursing and health worker groups. And as I said, in many respects, the early discussion and acceptance that communities may need to be closed and isolated, I think has led to a large contribution to the outcomes that we've had. And of course, then the national response with closures of borders and restriction of movements has protected Aboriginal and Torres Strait Islander peoples. There was a very strong media message as well that was coordinated by the Indigenous sector around that health messaging and the concerns for Indigenous peoples. and that was picked up by the mainstream media very early on. And I think that was adopted by a lot of organisations. There's a lot to be proud of as a country. The Native American situation is dire, and we may very well have been there had we not all buckled down and worked together.
So what issues for you are raised moving forward?
So specifically in terms of the Australian Indigenous Doctors Association, there have been a number of policy statements that we've made, and most concerningly, particularly in the current international political context with what's going on in the USA, was the issue around not only institutionalised racism but direct racism. We were having reports that were coming back. One area was Western New South Wales, and there was another area in Western Australia where there were either inappropriate comments or diversion of suspected COVID patients who were Indigenous away from those facilities. So that was raised fairly quickly by AIDA, supported by the peak groups, and then supported by relevant mainstream jurisdictions and health departments. So a very, very impressive response. So that was probably the most concerning area that was brought to our attention. But as I said, it was tackled very, very quickly, and AHPRA issued a statement that behaviour of that kind won't be tolerated.
And where do you sit with some of the issues that Ewan and John have brought up, such as a growing number of mental health issues, which has been predicted? This is the next epidemic curve. Ian Hickey's been talking about that a lot. The training pipeline, are those common issues at the moment? Are you getting reports back from doctors at the front line?
Yeah, look, a very, very big concern that's coming through is echoing not only concern around mental health, but the concern around general health. A number of colleagues doing emergency medicine have reported back delayed presentations of suspected cardiac infarcts and strokes and TIA. So instead of coming on the day of, they'll come 2 or 3 days later. In my own practice in ophthalmology, because a lot of my patients are quite elderly and they may need to come in for their injections for their macular degeneration, particularly when the lockdowns were occurring, patients were ringing up and electing not to attend those appointments. And also there's the chronic disease burden, people with diabetes, people with high blood pressure, cholesterol. I think there's a very genuine fear that if those chronic illnesses aren't addressed reasonably soon, now that it seems that COVID has stabilised, then that will almost present a second wave that's independent of the infectious agent itself. On the college front, look, wearing my hat as a fellow of the College of Ophthalmologists, I also sit on the selection board of RANZCO. And there was to be an announcement yesterday around the issue that John brought up and the progression of trainees through the pipeline. Again, very real issues in the early days around the need to suspend training to maintain safety for trainees, but also to ensure that the quality of training was maintained, so the people coming out the other end eventually were actually trained to an acceptable and appropriate standard for the Australian community. So a wider public health issue there. I was very pleased to receive an email that the college board has now looked at recommencing the vocational training program, and in fact the selection process for next year has been recommenced as well. So again, certainly my own college I think has been quite sensible in their approach and their response. And is cognizant of the workforce requirements. And, you know, I'm only speaking as a fellow of the college, not as a representative of the college, but that's certainly the feedback that's coming through to us as fellows.
Thanks very much. Fiona Wake from CRANA, the remote area nursing and the issues from remote areas that being raised for you.
Yeah, sure. I think workforce challenges, I'm sure everyone on the panel and those listening are aware, have been long-standing for our remote workforce, and particularly for our nursing. And I think this pandemic has just highlighted the the issues we've had around the workforce with the large numbers of fly-in, fly-out agency nurses we have, and with the closing of the borders, it has been harder to get workforce in and out with the isolation periods, and it's really difficult to reallocate staff into such a unique environment as remote. So you can't just pull someone from the hospital to go and work in a remote community. Under the scope of practice is completely different. You know, they're working under, like in the Northern Territory, under the CARPA manual. Yeah, so that's been a huge issue for us. I mean, we get nursing staff from New Zealand, so you know, international borders are clearly closed.
But just a point of clarification, I thought that borders weren't closed for you didn't have to quarantine if you were an essential worker, that you actually got in without that, and there's actually quite a free flow of workers in and out of borders at the moment.
Yeah, so there still are, there is still some 2-week period between that. So when we bring in agency staff, we book them for 8 weeks, and they do 2 weeks isolation and then 6 weeks outbush. Well, this is what's happening in Northern Territory for Top End Health Service anyway. But yeah, I mean, I don't think you can underestimate the resilience of the remote workforce we have. I mean, the local staff and the agency staff have been incredible in agreeing to take on longer contracts so that we don't have, you know, the turnover and as much instability in the workforce. You know, the staff have, we've actually, in the Territory, put more staff into community to assist with, you know, the preparations and for the pandemic. I mean, I think for us, the concerns now are, you know, perhaps when it actually hits us. I think we've done a lot of preparation. You know, our plans are in place. Our staffing is getting. Unfortunately, they're getting tired through this preparation phase as well, which is, you know, you wonder when it actually does hit us, if it hits us, but you know, when it hits us, how are we going to be able to sustain what we're currently, you know, doing in our remote communities?
What about the well-being of nurses?
Yeah, I mean, that is a huge issue at the moment. I mean, with CRANAPlus at the moment, our bush support services, which is a 24-hour psychology service that for remote health professionals and their families, we've noticed a 50% increase in calls to that BSS service between March and April compared to January, February, and 65% of those calls have been COVID related, and that's really significant. And I mean, just from me personally, speaking to the staff on the ground, they're you know, they're really unsure about, you know, what's going to happen from here, what's going to happen to their communities. Like, we've put all these plans in place, but it's when it hits, how's it going to unfold? And I think, and I go back to that resilience of our workforce. You know, there is this sense that people will support each other and we will do what's required when the time comes. I think one of the most challenging things, Norman, for us has been the mixed messaging that's come through around all the COVID preparations and the constant changes to guidelines and you know, what's required around testing and contact tracing, etc. And I think that's been some of the challenges for our staff. And one of the things we've done in the Territory has been to try and isolate the information that's specifically required for our remote and primary healthcare practitioners, so that we are the source of truth that's going out, that they see this newsletter, they see the guidelines on that newsletter, they look at the scenarios that are just relevant for remote communities, and they know that's their source of truth of how they find their information, because there's just so much information overload at the moment, and that's been you know, a number of my conversations a day in the early period is which guidelines do I follow? Where do I find this? Where do I find that? So that's been a learning curve for us around, you know, into the future, that we really need to provide clear information to our health professionals about what they need to know.
And what are you hearing from remote communities? Because sometimes you hear remote communities being a bit perplexed about this, saying, well, there's no cases around us, what's all the fuss about? And even the lockdown doesn't affect them that much because they're just getting on with life.
Yeah, I mean, there's been certainly different messages coming out from different communities. I mean, we've even had things like, because there's been this real push to get all the flu vaccines, and there's even been some thought that the flu vaccine is the COVID vaccine. So, you know, how are we communicating this with our communities? And when we're setting up our pandemic plans in the communities, talking with the local communities about, well, what does isolation mean? What is the impact on the local health centre? When you come to the clinic, there's a sign on the door that if you've got these symptoms, you know, you actually can't come into the clinic. There's a special area over here that you need to go and get tested. And the communities have been quite extraordinary the way. I think there was a lot of fear early on, and there probably is a little bit now as well. But you know, I think if we keep those communication pathways open with the communities, then that's going to reduce the fear a little bit around what's happening.
So, Tony Bartone, I mean, there are a lot of political issues that have kind of sitting there behind the surface here that have been either patched up, covered over, or not relevant anymore. So from where you sit, what do you think are the key pressure points moving forward?
Look, I would have to concur with a number of the themes that already come out this evening, Norman. I think that as we evolve through the remaining part of this response to the pandemic, mental health issues will continue to become by far much more prevalent and much more topical in the response. But I think we've identified already in the lead up the logistical and the pressure points and the logistic issues around supply of PPE, supply of essential medicines in that part of the response. So look, for me, it's about making sure the learnings that we've had to painfully endure aren't forgotten, because if there's one message, is that we've been predicting that there would be some sort of pandemic for a long time. We were expecting it to be an influenza pandemic for a number of years, you know, waiting for the next, you know, big influenza pandemic. But of course, we've got this one instead. But I think biosecurity measures issues will become more and more topical as we continue through. And so that, for me, is one of the issues to learn. The other one clearly is the opportunity for transformational change in primary healthcare delivery. That, you know, telehealth, and I know we'll talk about that in a moment in more length, but that was a game changer. But what that did was part of the health services really progressed in terms of innovation and delivery, but the rest of the system is still stuck back in times gone past, and we need to really bring the whole health service with us in the way that we're able to deliver care around the patients. And that's,
I get the impression with telehealth that there's a sort of self-congratulatory thing. Oh, we've got telehealth, but we haven't really thought through what the nature of a telehealth consultation is. The fact that you probably do need video, that phone is not enough. It's killing some practices because of the financial side of it, and we're relying too heavily on it. And it's almost as if that's primary healthcare reform over. We don't need to talk about it anymore.
And nothing could be further from the truth, as you and I both know. Clearly, that is just that's the entree. That's been the beginning of the conversation. We really do need to take primary healthcare reform by the horns and really progress it. We've been talking about it for so long, and what COVID did show was how vulnerable primary healthcare was to the initial shock, to the initial downturn.
Do you think the governments have realised through this, because everything was focused on ventilators, beds, specialist care, and oops, we better just think a little bit about general practice. I mean, do you think anything, things have moved at COVID-19 speed. There's no question about that. And it's been great response. But do you think governments are actually aware of the importance of primary care rather than paying it lip service?
Look, I think they've had to learn by painful experience the importance of that primary healthcare response, especially at the first point of call. People get, when they get crook, they go to their local doctor. Now, if it was the bushfires, the smoke earlier on this year, or now the COVID-19, the town or suburban GP was the first port of call for countless hundreds of thousands of Australians, and they were not prepared. They were not given the resources. They were not given the connectivity to deal with it.
All the people on this call would say they're still not, despite 4 or 5 months of response.
And in fairness, look, the only thing I'll say in fairness to them is that they got caught behind the 8 ball, and they've been really fighting in a global village for very limited amounts of resources, and tried to really rapidly bring that up to speed. But notwithstanding that, I think that is one of the key messages out of this, is the importance of the general practice and the primary healthcare team in terms of the population response. And if we continue to overlook that, we had the bushfires in Victoria back in 2009, and the aftermath of that was to ensure the importance of that. It seems that a decade on, it was all forgotten. We had the same repetition in the bushfires, and again in this early part of the pandemic phase. And we're doomed to repeat history again if we don't learn from that. And that, for me, will be the important part of really bringing that information back to the primary healthcare reform table in the months ahead, and making sure governments don't forget that.
Harry Nespolon?
Yeah, look, I think what COVID-19 and the bushfires have done has underlined the importance of general practice and its role in dealing with disasters and pandemics. But Tony's absolutely right. The great concern is, in 6 months' time, would we still have learnt the lesson? And so all of a sudden for state governments, it's been, oh, well, the general practice could actually keep some of these patients away from our hospitals. So that's good. I think we should be doing something about that. But at the end of the day, I mean, as we've known for a very long time, state governments don't really know how to deal with general practice very well. But they've learnt a lot over the last 4 months. The real question is whether they're going to take that forward. And look, it's certainly something now that, I mean, I certainly feel that the anxiety around COVID-19 has sort of started to decrease. People are now beginning to look forward, seeing, what are we going to do? Because where we're moving to is not to where we were before the virus came out. We're moving to a new place. And so if you're looking at something like telehealth or digital health, look, I just take up one comment. I mean, you might say that telephone isn't the best way to deal with telehealth, but given that we had no telehealth basically for 99% of our medical practitioners, and that 99% of the population actually do own a telephone, and 99% of the population don't know what Zoom is or didn't know what Zoom was, the telephone works. Now, whether that's what happens going forward is another issue. But we need to build the whole infrastructure around telehealth, which we don't have. I mean, we're hopefully going to get e-prescriptions soon. Not sure how soon. There's a whole area around pathology. There's a whole range about how we interact in our silos, and we still are in silos. I mean, there is a secondary healthcare system, a tertiary healthcare system, and there's a primary healthcare system, and never the twain shall meet. But hopefully that will change over the next little while. But you still need to build that infrastructure. And look, we didn't start building it. We haven't started building it until virtually now.
So you just wonder, lip service. There's one question here. GPs have responded well, but they're feeling stifled by red tape. Before we came on air, we were talking about the red tape associated with testing. I mean, is the College of GPs, and I'll come to ACRRRM in a minute, looking at this red tape issue?
We from day zero, we were saying that we need some authoritative leadership. We didn't need to have the Commonwealth saying one thing and 9 states and territories saying something differently. And that all got better as the anxiety increased and you got the National Cabinet. But now we're going back to that phase where you've got the National Cabinet meeting, and then as soon as the state ministers and state territorians and the territorians get out, they're saying something different. And all that leads is to confusion. And then back in the original part of it, as you might remember, people would follow the Singapore rules or the British, what the British were doing or what the Europeans were doing. And so we need, going forward, we need that sort of authoritative voice, the truth, as Fiona would say, about what the right way to do it, right approach is to COVID-19, for example, and testing.
I just wonder about this, because you could argue quite strongly that the success of the COVID-19 response has been because state and territories have responded well, and they actually got their act together, and they were much tougher about it than the feds were. Are we focusing in the wrong place in primary care? And should we actually be capitalising, even though there is a bit of variation there among states and territories, should we be focusing our attention on states and territories rather than the federal government, which probably has been a bit behind the 8 ball? And should, primary care organisations be focusing on states and territories more than they do?
Look, general practice is paid for by the Commonwealth, basically, and so we've got to go where that's where our part of the world is. The states have got their state hospitals. The general practice feels very excluded by what happens in state hospitals. All these bizarre referral rules and a whole range, if you're talking about red tape, that wastes general practice's time. But if we're talking about where the focus should be, again, I think, Norman, you can argue about whether or not, you go back to that argument about, is the cure worse than the disease? And it may be, you're quite correct, that the states were much more, or some of the states were much more, authoritative about how they were going to close things down. But some people might argue that because of that, we've got all this mental illness that's appeared now. And so that's been the cost of trying to eliminate the COVID virus.
So let's talk about workforce for a bit, just before I give you a hand, move forward. What's the College of GPs doing in terms of, specifically, not what you've done before, but there's COVID-19, there's been interruption, there's been, it's revealed even more workforce issues in rural and remote Australia. What's the College of GPs going to do about it?
Well, I guess going forward,
You're shuffling uncomfortably there, Harry. Is that what you're doing?
Oh no, I could tell you a story, but no. Look, we look from our point of view, we've filled up the number of people for the training program. We're about to go through and doing that selection process. But having said that,
including for rural and remote areas.
See, this is the problem, is if you don't, say at the moment we have issues in outer metropolitan areas, for example. And so the whole workforce issue is not just about rural and remote. But
this webinar is.
I know, but if you don't, my view for all it's worth is if you don't fill up your city practices, then you don't get that flow out into the rural areas. It's easy for people to stay in the cities. And so we need general practice to be oversubscribed to make sure that we do get that flow into rural and remote areas as much as any other area.
Ewan?
I think that one of the real challenges, of course, has been the trickle-out model, the tsunami model of healthcare delivery is something that just simply hasn't worked. And certainly for medical school programs, it hasn't. With real clinical schools, where you train people in context, you train local people in their own lands, in their own countries, in their own context, you do get increased retention. James Cook University clearly has the runs on the boards there. I mean, I always reflect on the college and the people that we train, and certainly in my context, are country kids. You know, and I certainly seeing those people staying and becoming part of the communities that they grew up in. So I think there is the trickle-out model it doesn't work.
So here's the problem. If we're going to solve workforce problems, we're going to capitalise that. I mean, while I've been critical, we have moved forward at speed and done stuff that's never happened for years. The National Cabinet potentially is a way to speed up things rather than COAG, which is a place where good ideas go to die. But you know, if there's division between colleges and organisations, I'm sure what's the possibility for unanimity of response? Because the politicians will just play that as they always have.
I don't think that we're that far apart, to be honest. I mean, you know, the College of GPs and ACRRRM have worked very closely together around the National Rural Generalist pathway. What we actually need is for the government and for the department to get on and get that process moving. We've had significant delays over an extended period of time. COVID-19 has been used as an excuse to further put things back, but then to put in place stuff that hasn't been well thought out. So I think that certainly National Rural Faculty has worked very hard with ACRRRM to look at this National Rural Program, but the other part of this story is actually getting local people, Aboriginal and Torres Strait Islander people, local country people, people from regional Australia into medical schools and training them in the regions, because we know that if you go to Sydney University, apologies to Sydney University, but they'll bash the rural out of you. There's no problem about that. Going in, but coming out, rural intent does drop off quite significantly. So you've got to do it local.
We've got one question here, which I'd like both Fiona and Chris to answer. How do you know, this gets the lockdown of remote communities versus the mental health issues, and when do you actually lift that and balance, you know, the risk in a low COVID-19 prevalence environment? Chris?
Yeah, look, it's a difficult question to answer because we don't know everything about COVID yet. Our approach has been that certainly for a lot of the rural and remote communities, by their very geographical nature, they're difficult to access, and it absolutely is correct that the highest risk group coming in and out of those places are generally your health staff. It's your fly in, fly out clinics. Now, AIDA's position on that is that we have to take a very, very cautious approach and a balanced approach to reopening those services. And the balance has to be, as I mentioned before, it has to be a balance between ensuring that the chronic disease burden is not worsened by an absence of specialist care or nursing care, whatever is required, but also that the staff coming in are as best as we can determine clear of COVID. So the approach really is a practical one, and that is that for the time being, individuals going out to those areas would need to maintain a 2-week quarantine period to ensure as best we can that they are clear of COVID. And look, until we know more about how long it can remain asymptomatic and how long people can carry it for, and is there a re-emergence, there's a whole lot of debate in the literature about that, and it's a moving target. You know, it's a novel virus, and novel by name, novel by nature. And so we just need to be very, very cautious about that. But you're absolutely correct. The workforce impacts are enormous. And the more remote you go, the more responsibility is placed on not only our Indigenous health workers, but our remote nursing staff, who do an incredible job and are enormously skilled, but who do run that risk of not only being isolated, but being burnt out. I think also in terms of telehealth, there is an opportunity in that rural remote Indigenous space to perhaps not only define how telehealth can be utilised in that context, but how it can actually work and how how it can be delivered. In a purely ophthalmic context, there is an ophthalmologist in Western Australia who's been doing telehealth very successfully for a number of years, and doing a lot of the early, not only triage processing, but early consults on telehealth and video health and planning before they go into those communities. So it's a rich vein, but as I said, the practical approach at the moment is 2 weeks isolation to ensure people are, as best as we can determine, clear of COVID before they go in. And I think that has to remain for the foreseeable future.
Fiona?
Yeah, and I think that you know, from you know, the Northern Territory, we're seeing that some families or individuals are choosing not to come in for appointments or specialists, or because of that 2 weeks of, well, you know, anecdotally, because of that 2 weeks of isolation, or for whatever reasons, you know, families and community members are choosing not to come into to Darwin, and then yeah, there is a sense that you know, the communities expect us to isolate for that period, and if they don't, then you know, there's questions asked. The other thing we're doing in the Territory is sort of enhanced testing. They've started this enhanced testing at the moment, which is if you come with any symptoms whatsoever, you get tested. So we've upped our testing to try and catch it early as much as possible, and then we've got good guidelines around contact tracing as well, so that we can catch it quickly as well.
John Hall, what do you think is the role of PHNs moving forward? I mean, I think that the good PHNs have risen to this. You've seen some good things happening. The ones that were struggling probably struggled even more. You know, privately, the Commonwealth's still frustrated with some PHNs. I mean, when you've got good ones, they really do, you can see the potential there. How do we lift, well, first of all, do you think that the PHN as a concept still has validity? And if you do, how do you lift them so that you actually have less variation in quality or effectiveness between them?
Look, I think we've seen a failure of the PHN process when it comes to distribution of PPE to general practices, and the government using that as a channel. It's been really unfortunate. As you said, there's been some effective PHNs, but far and away we're getting reports that that's been an issue. And you know, we're actually working with the department at the moment to look at sourcing PPE for rural practices now. Still, it's a major issue, particularly non-mask PPE. So that's a concern in and of itself. We've seen PHNs drift away from the divisions of general practice, where they essentially provided direct support for GPs, to something that's taken the focus completely away from general practice. And we're seeing, you know, large volumes of money being spent in places that, you know, are probably not necessary when general practice is bleeding. So at the end of the day...
What's your issue there? What are you talking about?
Well, I think, you know, their focus has been on provisioning allied health. You know, we've got this concept of a healthcare home where you could be building up teams around quality general practices and funding that appropriately and supporting practice entities, when this money's being taken out of primary care, out of the front line. In fact, a lot of the PHNs are being told they can't spend money on frontline general practice, when you've got many rural and remote communities that are struggling to actually employ allied health or recruit allied health. And there's provisioning that's going on through PHNs, which is going to contracts, and you're getting a lot of intermittent fly in, fly out, drive in, drive out allied health, and leaving many rural communities without that support. So look, at the end of the day, I would support better direct support of general practice, better funding at the coalface to help us build our teams around us, pharmacists, allied health, Indigenous health workers into general practice. Now, recognising that 50% of Indigenous Australians are managed in non-NACCHO or non-community controlled health organisations, and really supporting general practice to deliver care to its communities.
Don't you need systemic infrastructure to actually, so that you've got people that you can actually team with and that's the purpose here, is that unless you've got an organization which has a geographic and population responsibility, the individual general practice hasn't got the capacity to create jobs and infrastructure so that you've got an allied health team to work for, because the community wants allied health. They want physiotherapists, they want psychologists, they want occupational therapists and so on. They want that team there. And general practice has historically not been good at finding them.
Well, look, it'd be good if the PHN supported that and funded it into general practices, which I don't think is happening. Yes, it'd be good to have a community-based organisation that understands the healthcare needs and directs that support and funding into general practice. We've got a situation where general practice is on its knees. COVID has exposed that, and the government's spending money on programs and systems that, when you've got a primary healthcare system that's broken. So it's about priorities. I think that's a nice thing to have, but they're putting the icing on the cake when, the cake's gone flat.
But let me push this for a little bit. North Coast New South Wales has managed, PHN's there, Coffs Harbour up to the border, has managed to cash out mental health with the hospitals and the PHN, so that GPs, and you start using mathematical modelling to actually work out what's needed there, because what happened in Western New South Wales was that they funded mental health education for the community and mental health training for GPs, and all that did was you had better diagnosis, more awareness, but no services for GPs to refer to, and therefore you got a crisis. You potentially could have got a crisis developing. So there's a PHN that's actually doing stuff that general practice by itself would never do.
Yeah, look, I think they've got a place in providing quality support, data support around PIP-QI and some of those processes. But at the end of the day, as I'll reiterate, I think general practice at the coalface through the MBS, through other systems, is just chronically underfunded. And we need to get that right before we can coordinate care at the end of the day. Tony
Bartone?
Couple of quick points. Remember that the divisions and then ultimately the PHNs was foregone funding out of MBS increases way back when. So let's just not forget that. I think John's right, and you're right. Both models need to be funded efficiently and effectively. They both have a role to play. The example you gave of the PHN there on the central north coast there is a good example. And, Brisbane North is another one, the Southeast Division of in Melbourne. There are numerous really good functioning PHNs, but there are some real basket cases, and I'm not going to obviously name them, but clearly what we have a lack of uniformity of service understanding amongst them all. It comes because they're being asked to do more and more without the necessary funding. And that's one of the issues. I'm not saying giving them more funding when they're not functioning, but clearly they're being asked to do more. And as every new crisis or every new episode requires them, they get lumbered with more additional tasks. But there is that, when you don't have a properly funded general practice to begin with, and some of them compete in service delivery when there's not true service, failure, market failure. Really, we've got a confusion. So unless there's really good collaboration between all the PHNs to uniformly bring them all up to speed, bring them all up together, we're going to have this problem of the good ones and the bad ones. And the people who suffer will be the patients in those population areas there. So there is a role for them, but they've got to be more effectively communicative and collaborative with each other and be held to account.
Ewan, what's a constructive way forward here? Because they're not going away. And the good ones are frustrated because they're dragged down by the ones that are not performing well. They all complain about the Commonwealth putting restrictions on them that don't allow them to actually tailor their plans and strategies to local needs as much as they should. What's the way forward?
Look, the way forward, I think, is that, to be honest, the profession and the communities need to lead this. When the department is defining what needs to happen, you're going to get department outcomes from it. Basically, the PHNs and my PHN, a really effective PHN. They've got all the information. They know what needs to be done. If they, with the clinicians on the ground, with communities on the ground, to design services that actually deliver, and are given the imprimatur to do so, it'll make a big difference. But it needs to be funded. People need to be empowered to get on and do the right thing. When you're just sitting there punching in numbers and reporting stuff all the time, largely a lot of it irrelevant, but irrelevant to somebody's work plan somewhere in Canberra, it's not effective.
But the implication there from John and Tony to some extent is that you're robbing Peter to pay Paul. You're in competition for the same dollars.
Yes and no. Look, I think that one of the things about commissioning, for example, is like we wanted to deliver a wound management program. So we actually wanted to put in a tender for that. Tendering for stuff is not traditionally what general practice does. Maybe the bigger entities do, but a small general practice tendering for money. But the people that got the job at the time were in Brisbane, which is 1,000 kilometres away, and they were going to come and educate us how to treat wounds. Well, that sort of wasn't the point, because we've been treating wounds out here for a lot longer than the people who are educating will probably were. So look, it's about lifting the standards, lifting the expertise of general practice to make sure that we can competitively get that money that's out there that is currently being given to other entities with a nice name and a flashy badge and an office about 500 kilometres away.
Harry Nespolon?
Look, I'd go back to what you've just were talking about. You've got one PHN presumably cashing out mental health consults. I mean, why isn't it spread out to the other PHNs? When we had the QPIP, we were actually pushing, the college were pushing very hard for the Australian Institute of Health and Welfare to deliver the feedback, because we believe they're a much more efficient and much more appropriate group to deal with that large amount of data and actually produce better results from it. So the question is, one of my concerns about the PHNs is that, if you've got a hammer in your, if you've got a hammer in your hand, everything looks like a nail. And so the department has to look for things for the PHN to do, rather than saying to themselves, well, look, this is a program or a set of work that we need to have done. What's the best way of delivering it? And it's not necessarily the PHN. They might be able to do it efficiently. They may not be. Now, commissioning was that very exciting part about when PHN started. I'm not so sure that commissioning is quite at front of mind anymore.
There's partly the GPs that wanted commissioning because they felt that PHNs were setting up as organisation. Now you're complaining about it, and it was GP organisations that said that that's what they should do because they were setting up organisations in competition to general practice.
I don't think the college was saying that. Look, as I say, I think we do have concerns about the PHNs in the sense that they do act as competition against general practices in some areas, which is not such a good thing. But again, it's about the variability of quality, and it's also, even if they're operating well, you've got to ask the question: are they the best group, or are they the best organisation to deliver particular services? They may be.
I'm still getting an us and them thing where you're both working in primary care. There has to be a way forward here, surely.
I mean, Norman, I know we're here talking rural, but if you come to my practice, yes, we do have a physiotherapist, we have a dietitian, we have a whole range of allied health services which have had nothing to do with PHNs. Haven't had any help from any PHN. We've got psychologists, we've got a whole range of services that we offer within our practice. Now, I understand that in rural areas that may be a little bit more difficult to deliver, but my understanding is that in a lot of rural areas, rather than on a fee-for-service business, that people physiotherapists and psychologists are happy to work on a salaried basis. Now, so the question is, are PHNs the best people to deliver that, or should we be saying to practice owners and practice managers, perhaps you guys should be delivering that, cut the middleman out, and have extra services?
So, Chris, what's the sort of feedback you're getting from community controlled organisations in terms of the relevance of PHNs for them?
Look, to be honest, very little. I don't, as president of AIDA, I hear very, very little about the PHNs in the context of our members. I mean, we have a lot of GPs as members of AIDA. I mean, operationally, you know, my CEO sits on the task force alongside Nacho and on the National Health Leadership Forum as well. So there may be something there, but in my position as president, I hear very, very little.
Fiona?
Well, we sit on, CRANA has a seat often on the advisory committees within PHN, and so there's some input there, and I would assume that some of you guys are involved on those advisory committees too and can provide feedback to the PHNs about where the gaps are.
Well, most would have GPs as chairs of their boards.
That's right.
Significant there, but yeah, carry on. Sorry.
Yeah. And I mean, I haven't had a lot to do with them personally, but I mean, I know from a Northern Territory point of view, all the PPE seemed to go to the PHNs, and then they became almost like a distributor of PPE to GP practices and out to remote. So I think they are whatever they try to be, whatever they need to be at the time, whatever the time is, you know. Yeah, I don't really have much more to say about them.
I want to get a sense now, because it's 9 o'clock, we've got a little while left in the thing, but I just need a sense of common vision here, if there is one. And I suppose that's my first question, is there a sense of common vision moving forward? Or now that this crisis is over, we revert to type? And so we've done great things, we've response. Yeah, we faltered, but we've pulled together. We've got one of the lowest rates of COVID-19 in the world. You know, along with New Zealand, we are, so great things have happened, and we've moved at speed. There's the opportunity for a unified vision. Do we have one? I'm still hearing the same language. Now that the heat's off, what's going to change?
I think COVID-19 is a massive opportunity for the government to implement rural health reform in rural health. I think it's the area of the greatest...
Can I just interrupt you there, John? Okay, that's fine. But then you'll have it done to you rather than a unified response from communities and professional groups and others, which says to government, this is how you should do it. Otherwise, it's going to be a bureaucrat in Canberra telling you what's good for you.
Now, we've all, as a group here, a lot of these peaks have communicated to government the things that we feel need to change. COVID's shown us that the government can change. It can be nimble. It can implement things quickly. It can accelerate a digital transformation. We need to use those gains now to make sure that we improve rural health. Rural health is the biggest area of need in the country. We're talking about premature death rates in rural and remote Australia that are 40% higher than the city. We're talking about a fractured health system with public and private, as Harry was saying about the MBS funding primary care and the state health departments funding secondary care in rural areas. That's completely fractured. That's the root cause of why we're not integrated into disaster and emergency responses, because state health departments run those responses and GPs aren't visible to that because we're funded by the Commonwealth. We've got real opportunity to actually get the state and feds to work together on a unified plan for primary care in the bush, remembering that primary care in the bush also includes hospital, rural generalists, birthing, surgery, and all of those wraparound services that is rural health, and delivered by Indigenous healthcare workers, remote area nurses, rural generalist doctors, rural generalist nurses, and hopefully rural generalist allied health in the future. We've got a real opportunity to make a change here. And I think if there is going to be persistent telehealth beyond COVID, it needs to start in the bush. Our workforce programs need to start in the bush because that's where the greatest area of need and inequity is in Australia right now. We've got one of the world's best healthcare systems, yet we still have gross inequity when it comes to Indigenous health outcomes and rural health outcomes. So if we're going to talk, we don't have enough GPs in regional areas and we don't have enough staff in other places. I think we, as a community, we need to look at where the biggest disadvantage is, and we need to be focusing on getting that right first, so that all Australians actually enjoy equity of access and availability of healthcare before we start to add on layers of, I guess, nice to haves and, other things that are really just an add-on. We're talking about basic human rights. I think that access to emergency services, birthing, and quality primary care are basic human rights. And today, based on those premature death stats that I quoted from the Australian population study out of the University of Melbourne, which was published this week, we're seeing an increase in the health life expectancy gap in rural and Indigenous Australia, not a decrease over the last 10 years. So this is urgent, and I think we need to use this crisis as an impetus for change.
I can I say I think you're absolutely right, John. I think what you're saying is true, but the realist in me is very suspicious that what will occur is that we'll end up in a difficult budget situation, and that will overtake the conversation. And despite our best wishes and learnings from this, certainly the Indigenous lesson has been that the economic situation that will unfold is likely to take us all out in that. And I think that's a backward step, I apologise for being so negative, but I suspect that's what will happen.
But it doesn't.
Sorry, Chris, if we got telehealth, meaningful telehealth into remote Indigenous communities and to rural, I mean, the total cost, because the population is low, would be, very low for the government, but you could have a massive value add when it comes to health outcomes. So, making sure we've got good access to face-to-face, but using this technology to actually make a real difference, the biggest difference that it could.
But I was coming to Chris, you could call it pragmatism or pessimism in terms of what you were saying there. But you've got less likelihood of that happening with a unified voice across the system. And therefore, what's the call? You've got, I mean, okay, you're representing Indigenous communities, and John's right about that data. And South Australian data suggests that the life expectancy gap in Australia is actually 45 years. If you take Central Australia versus a rich suburb in Melbourne or Sydney, 45 years, not 11 years. And it's extraordinary, the gap. But it's symptomatic of a system as a whole. What's the call? What's the unifying principle, Chris, that brings people together from such diverse priorities?
Look, I think it's around exactly the messaging that you just gave, and the response that John gave, that we are one of the world's richest nations, in material health, and we have the ability to know how to do this, and that it's incumbent on us to do that. And I think very clear messaging around that, and also an element of, it was suggested earlier, some autocratic leadership, people in places within government and government departments particularly, who have the fortitude to make those decisions and roll them forwards. I think the sector knows what needs to happen. That's certainly represented here tonight. And I think we all sing from the same songbook. It's about having people in positions of power who make those decisions on board with that as well. I don't know how you solve that. A number of other areas in society have been very successful at change, and a lot of that advocacy has actually come through the long game. And that's not just a long game of internal advocacy, it's external advocacy as well. And, maybe we need some campaigns, some media campaigns, long burns, 5-10 year projects to really have the Australian public understand that, and therefore have that trickle through to those individuals I mentioned in those positions who make decisions. I think as a profession, we actually don't do very well at the fight. I think we are very reluctant to, as a group of people, very reluctant to go in there and sort of arm up and get on with it. A lot of our colleagues do medicine because they love medicine and it's about their patient, and they're not there for the politics. But as a profession, if we continue down that road, I think it's a slippery slope.
Tony Bartone.
No, look, if we look at what was one of the successful parts of the government responses, and that has obviously been national cabinet, and then the way it was implemented at a state or territory level. What they showed was if they put their mind to it, they could, with single purposeness, come out with quick, effective, innovative solutions. The issue that connects all of us on this telco tonight, on this webinar, is primary care. That has the ability to deliver outcomes at both a Commonwealth level, but obviously at a state and territory level. And that's what's been missing in the whole discussion in the years gone past. And that's why governments have not been, federal government has not put money into primary care as much as it should, because the benefactor would be the states. And the states have been benefiting from primary care without really having to put any money into it. And they're only waking up now that actually a really efficient and effective primary care service will actually benefit them and keep the pressures off their secondary and tertiary hospitals. It is a long game, but the clever thinking is now. And if you have the collaboration, the innovation, remove the duplication, remove the waste, you will get outcomes in the long run that benefit everybody. And that's where this national cabinet has a real ability to cut through what COAG couldn't. And that is that there is a real need for everybody to roll their sleeves up and contribute. Everyone's got skin in the game. And if they don't, now the message for us is that we need to be unified in our message to state and territory and federal. If we all go to the various parts of the government process in this with the same message, it's going to be harder to ignore. And you're absolutely right in your comments earlier this evening. We need to get ourselves as much aligned as possible to deliver a really strong and effective message. Yes, we could revert back to type, but I think in a really constrained environment of resourcing and funding in the future, because of the debt that we're about to have to start to pay back, we need to be even more effective, more efficient, and more targeted and more on song.
So where in the politics do nurses fit in this, particularly rural remote, Fiona?
Yeah, well, I was just thinking while Tony was speaking there, what a voice we would have if we joined together in that voice, you know, how powerful that would be. And certainly CRANAPlus, you know, advocates for rural and remote nurses across Australia and provides a voice for them. But we need to be collaborative in this, because I think we often complain that we're not consulted about decisions made at the highest levels. But yeah, if we joined together and had that you know, joint voice together, I think we really could make a difference.
If I can just make a comment there, Fiona, the Indigenous experience with Indigenous Allied Health Australia, CATSINA, which is the nurses group, NATSIWA, which is the Indigenous Health Workers group, and AIDA, which is the doctors group. All of the CEOs of those groups know each other and meet regularly. They have the National Health Leadership Forum, and the messaging is on key and concise and clear every single time. And very, very rapidly, we've achieved change in policy and direction and funding requirements in the health sector, because each of those areas in the health sector have got together and fleshed it out in the back room and then gone to ministers and governments and said, this is what we need. And I think there's a very important lesson for mainstream there.
Yeah,
and absolutely echo what you're saying, that if each of the groups in the healthcare system get together, work our stuff out and go to government, it makes it so much easier for government, because they've got a one-stop shop with one message.
Yeah.
Norman, the RDAA recently reinvigorated UGPA, United General Practice Australia, which is a group of peaks that sit around the table and do exactly this. We're hoping at the next meeting to talk about telehealth and GPs in disaster response and training going forward, so we can do exactly what Chris was suggesting.
Yeah.
Harry?
Oh, look, I think the rhetoric matters, and at the moment our interaction as primary care when it comes to secondary care is about hospital avoidance, and that's about the only message that we've had for about the last 10 years or more. And from my point of view, that's just too narrow, it's a very negative sort of message. It's just about the only reason why primary care exists is to keep the hospitals empty. Now, ironically, with the budget situation as it's going to be, there probably hopefully won't be too many more public hospitals built, which will be a very positive thing, I might add. Also, interestingly, in New South Wales, I don't know what's happening in the other states, we're beginning to see research from the New South Wales Department of Health looking at how tight patients are with their GPs, and the tighter they are, the less likely they are to go to hospital, even though it sort of contradicts what I just said in the beginning, which does open up the possibility that if the states are willing to invest and willing to change their systems so that general practice is actually at the forefront rather than something that you just send results to, that they may find that they don't need as many hospitals beds. They might not need as many outpatients. They might start to think about moving some of those outpatient services into general practice at much less expense and much better result for patients. Patients in general don't like going to hospital last time I looked. Most of them are quite happy to come and visit their GPs. But that's a whole of system change. And in answer to your question, how do you get that? Unfortunately, it's very incremental, but there is a possibility there to deliver a much cheaper, much better, much more patient-focused system. But again, it does require a lot of advocacy and a lot of data.
So there's a couple of questions there. I'll just go through, there's one I'll just refer to now. They're asking me for the reference for the 45-year gap. So the reference for what John was saying was Tim Adair and Alan Lopez in Australian population studies, and you can find that on the health report. I did that not last month, not this Monday, but Monday before. And then there was a study from the University of South Australia, which is where the 45-year gap comes from, which was a local area life expectancy study and morbidity study out of the University of South Australia. I actually had it on the health report maybe 4 or 5 months ago, but I'll give that to RDAA and ACRRRM so that maybe you can go out in the bulletin so you've got that reference as well. So one question here, which I think is relevant and mea culpa on this one, is well, where does the patient and the community sit in all this? You know, this has been a top-down discussion. I'll take the blame for that because I've been directing the questions. Where, you know, just the final thing here, in terms of this move forward for a better world in terms of primary care in rural and remote Australia, but it's for rural and remote Australians, people living in those areas in all their diversity. Where do they sit and how do they engage with this process? And I'll start with Chris because, you know, the engagement is probably much better in Aboriginal communities than it is elsewhere. And what lessons can we learn from that elsewhere? Chris?
I mean, from the Indigenous experience, as we know, 50% of our population is seen in the community-controlled sector and 50% are in non-community controlled. From the community-controlled perspective, it is, as its name suggests, it's community-controlled. And the boards that run those organisations are voted in by the community each year. And you have some often quite lively and ruckus debates in those election processes. And so the individuals who are advocating and making decisions around the health system are a part of the community. I think there's a great lesson there that, you know, it's like the old hospitals. Your med super had a personal responsibility for the way the hospital ran, and I think it's very true for some of our rural and remote smaller hospitals, and not so much our large urban ones where the med super had patients in a bed and they were a part of the fibre of the community.
But applying that more widely, isn't that the idea of the PHN, that you get more community involvement than you can within the business model of general practice?
Yeah.
Such an enthusiastic response. Where does the community and the patients sit in all this?
So is that to me, Norman?
No, let's go to Fiona first.
Sorry.
Oh, sorry. Yeah, I mean, it's such a critical part of everything that's happening, that we're listening to our community, and that activities are done in consultation with them. So decision making comes from, you know, the community. And I was just thinking about this in terms of, you know, when we're talking about growing our own as well. Imagine if we had really strong workforces within our communities that would have those conversations within their communities, with their families, and with, you know, with local people around, you know, being a voice and making sure what was happening was understood and was agreed upon. And we know that, you know, when people make their own choices about things, you get better outcomes. So I mean, from my perspective, you know, that is an absolute critical part of any decision making we make, should be in consultation with the communities and with their agreements, whether it's changing our service, whether we're removing some of our services, what's the impact going to be on the community. Yeah, it's just, it has to be a part of all our decision making.
Tony?
Look, obviously at a rural and regional level, community involvement's going to have to be really fundamentally crucial to.
How?
But how? Well, I mean, it's far be it from me to suggest, because I don't have the community experience there. But whether it's directly into the practice or whether it's into the population health and community resourcing. So I'm a big believer in health literacy. And I think we do that really poorly in Australia, and we don't have the information and the sharing and the empowering of the community to make those choices and make them at a wider systems level. And then the community will be able to direct what are the resources that they need at a population level locally or more widely in that respect by influencing the politics of who's, you know, and how that's allocated. And at a suburban level, it's obviously going to be more difficult. And that's, I suppose, where we look at things like Bodenheimers and the quadruple aim, and the importance of having patient-centered care being part of the way we deliver our care. Because patients will, if they're happy and they're made the centre of this, they'll act on their own and more widely empower those around them. And I think that's a longer-term play. But I mean, clearly we've got to be able to get the data, put it in the hands of the local population, and be able to determine what their needs are and what their wants and resources are required.
Harry?
I'd go back to Ewan's example about wound management and patient-centeredness. I mean, we talk about it all the time, but whether we actually put it into practice, we had, even in the city, we had the same example. The local major hospital decided they wanted to do wound management, didn't talk to a single GP, didn't talk to a single patient about it. They just wanted to run it out of their own hospital. Look, I think it is about, and I think in many ways rural communities can have the best of worlds and the worst of worlds. I mean, the best of worlds is that you don't have a huge number of people. The worst of worlds is that you don't have a huge number of people, so you don't have that sort of push. And so, as I was trying to say before, we need to move away from doctor-centric models, which we still have, and move closer to exactly what patients want. And, you know, basic stuff like not having to go to hospital to do basic sort of medical events and procedures, and having the patient truly in the centre of the circle. How you do that does elude us a lot of the time.
John?
Oh, look, I think this is something that we've done reasonably well in the rural space, and particularly there's exemplar, models where this has worked. You've got Ewan's practice at Emerald, which is community owned. You've got many of the medical student programs like John Flynn that parachute students into community, where they connect them with a local group like the CWA, and they live with a local family. I think local government's really important. So places where you've had good succession planning has been where you've had the local government involved in financially in the practice or supporting the accommodation for the doctor. I've met with a number of local mayors in country towns, and they're very passionate about the local healthcare of the community, and they can tell us what their community wants. We've facilitated many campaigns around rebuilding maternity services, for example, where we understand that the government's not going to listen to me bleeding in the halls of Parliament House, but if there's a mob of angry mothers protesting in the streets of Emerald or Chinchilla or Charleville, they actually listen. So we've seen three birthing services reopened in rural Queensland off the back of community engagement, local government and community protest. So I think the rural voice, the rural community voice is often not heard. We've got many rural seats rural electorates that are conservative, safe conservative seats. So, you know, they often suffer from being too safe, and they're less relevant to the other side of government as well because of that. So I think one role that we as organisations can play is actually helping to facilitate communities to have a voice, listen to what they want, but then also help them to be loud and give them the channels to project that voice. And I think supporting them through social media, supporting them through our own channels, partnering with publications around, you know, local newspapers and local government publications. I think it's all about embedding in the community and facilitating the community and listening to the community.
Ewan?
Look, thanks. Thanks, John. Look, I've worked in my practice now for 5 years. It's been owned by the community. The local government is on the chair or the committee. But the fundamental structure of general practice still impedes it. The structural reform of general practice needs to happen. The way we deliver primary care in remote Australia is different from the way we deliver it in rural Australia, the way we deliver it in regional Australia and then metropolitan. The one-size-fits-all approach to general practice and primary care, the four walls office-based model, you know, we need to completely and utterly challenge that. What I would love nothing more is to be able to pay my nurses well, recognise them for the work they do as independent clinicians, you know, rather than having me sitting out there pedaling on my bicycle to make the money to pay everybody else in the building is just crazy. We need to think about how we do things differently.
Look, can I thank all our panelists? It's been a great discussion, and I think that the overall message here is that divided we fall, unified we succeed, and there is a golden opportunity now with changed federal structure, people having seen how fast you can move, where politicians not quite under the aegis of the bureaucrats as much as they have been. There's a great opportunity here to do stuff in primary care across Australia, across rural and remote and regional Australia, and through disadvantaged communities and Indigenous communities. So I think it's been a really interesting and important discussion. PHNs will feel a bit wounded, but they probably, some of them to really do need to think hard about how they're doing what they're doing, and hopefully they can join this rather than being out there as other. Thank you all in terms of the people who joined us, the many people who actually joined this webinar and asked so many questions. Sorry I didn't get to them all. Most of them were actually comments. You've been talking to each other quite actively, I see, through the Q&A. And if I'm sure you'll want to relive this experience. And if you do, this will be available on the ACRRRM and RDAA websites. And thank you to ACRRRM and RDAA for organising this. And it's really important for participants to fill in the evaluation form so that we know how we can make these webinars as good as they can possibly be for you. So thank you all very much again, and good night to you all.
And good night. Thank you.
Thanks very much.
Thanks.